All right, well, I guess we'll start and I'll just give a brief introduction as people continue to log on and join us since it's 1 o'clock. This is the newest iteration of research brainstorming session. We are across the Creighton School of Medicine, so Omaha and Phoenix. And with daylight savings time ending in November, our meetings in the spring will shift to be noon in Phoenix as we become just 1 hour apart. So it'll be 1 p.m. Omaha, 12 o'clock Phoenix. That won't be until, I think, not until our January meeting. Today we have Dr. Gelineau van Waes and Dr. John Cote presenting related talks on endometriosis, their mouse model, and novel therapeutic mechanisms assessment using that model. So we'll have 2 really short talks and some time for discussion. We also then have a meeting on nephrology the last Friday in October, presented by Tal Teitz and Khalid Bashir. And then the 4th Fridays of the month for November and December fall on the holidays. So we won't have meetings then, and then we'll start up again in January with 2 talks from collaborators, Ji-Yan Huang and Melinda Burnett. So if any of you are interested in presenting, I mean, the purpose of these talks really is to stimulate discussion and help people move projects early in development along, or find collaborators, or provide exposure to students and trainees, all of those different things. So the intent is not to have a perfectly finished, polished seminar. So if you've got some work that you're developing and you could use some input from a pretty broad scientific community and clinical community, I encourage you to reach out to me or to Brianna Conyers, who is now setting up and organizing these for me. Thanks to her for making it happen, and we'll get you on the schedule. Okay, so we have an hour, and Dr. Cote is going to start. I think something like a maybe 15-minute or so presentation by each of you will allow us some time for discussion, maybe 15 to 20 minutes. And then we still have a little bit of time to discuss and finish at the end of the hour. So thank you both for agreeing to talk today. And I'm really looking forward to hearing about your work. Dr. Cote?
Yeah, thanks, Dr. Hansen. Yeah, I'm just getting ready to share my screen.
So you might, I guess you've got your affiliation there, but since we are pretty diverse, that might be helpful just to introduce yourself at the start too.
Sure. All right. As you guys may not know, I'm Dr. John Cote. I'm one of the obstetrician and gynecologists here at Creighton and CHI Women's Healthcare at Lakeside in Omaha, Nebraska. And Dr. Gelineau van Waes and I are going to be talking about endometriosis. Before we get into that, though, initially when Dr. Gelineau van Waes and I kind of started getting together, I told her, I was trying to hang out with my nerd friends. So I kind of take this very seriously, even though I'm a clinician. I love to do the research, and I think this translational piece is very important. And so if anyone's like a Game of Thrones fans, which I am, you can kind of see that the font is kind of a Game of Thrones font. And then there's a quote from Cersei Lannister. I always told Dr. Gelineau van Waes that I felt kind of like Jon Snow, the bastard child coming in, because I'm not used to playing in your realm. And ultimately, when we deal with with that. I call her, Khaleesi, and I'm kind of that guy that just is sitting in the background. When we talk about endometriosis, though, we need to know what it is first. And so I want to kind of just do a brief primer. We know that it's an estrogen sensitive endometrial glands and stroma that we see outside of the uterus. So if someone has endometriosis, that's what we're going to see. By definition, then you have to find those glands and stroma outside of the uterus. About 10% of all women in the US are afflicted. We think the number is probably higher, about 176 million women worldwide. Sorry about that. So when we deal with the economic burden, which I think clinically is very important, we know that there's over $47.5 billion per year in the US. And that kind of puts it into some kind of quantitative view of this is very expensive, a very important disease state that some people may or may not know about. When we talk about the causes of endometriosis, they're theoretical causes. We don't know for sure. Probably the most important cause that people think about is the retrograde menstruation theory. Sampson's retrograde menstruation theory kind of postulates that the glands and stroma get outside the tubes, just like you would have a period and bleeding through the uterus and out the vagina. You get some of that tissue out the tubes, and then it implants into the peritoneal cavity and creates the endometriotic lesions that will create problems for women. And we've got two kind of pathways in. Either we're going to be dealing with endometriosis in terms of fertility issues, or we're going to be dealing with endometriosis in terms of pain issues. When we talk about pain, you can kind of see this study looked at all the associations or correlations present within women with endometriosis in terms of their pain. And I usually say that there's a trifecta. You're going to see dysmenorrhea, non-menstrual pelvic pain, and pain with intercourse or dyspareunia. But you also are going to see some of these other pain syndromes, or the pain that's going to be described by patients. Now, risk factors become important because when we deal with women clinically to see if they potentially have endometriosis, you try to look at some of these risk factors: early menarche, short menstrual cycle, heavy menstrual cycles, nulliparity, being Caucasian, and then if they have abnormal uterus, like a uterine didelphys or bicornate uterus, those would be women at risk. We also know that there's a strong familial component, so that first-degree relatives have an increased risk of about 7 to 10-fold, which means ultimately there may be some genetic pieces here that we can kind of collaborate with people. The WNT4 mutation or WNT4 genes kind of are associated with sexual differentiation, and in some studies they've looked at this. When we diagnose endometriosis clinically, though, without having a surgery first, a lot of times we may use ultrasound, and in this case you can see on this image that darker area, it's a grayscale with the ultrasound, and that's very consistent with an endometrioma, which would mean someone has endometriosis. MRI can be used to evaluate deep infiltrating endometriosis as well. The gold standard, though, is surgical visualization and histology. In fact, if we just looked and didn't take a sample, there's only about a 54 to 60% positive rate with what you think would be endometriosis actually having the true diagnosis of endometriosis. So that becomes difficult for some women to say, hey, do you need to have a surgery to actually diagnose this? And the answer to that is complex. Clinically, the answer is no, but in some studies and in some circles, they argue that the answer is yes. When we deal with the diagnosis of endometriosis, the ESHRE is the European Society for Human and Reproduction and Embryology. They kind of have this newly set up set of pathways that they say, hey, this is how you may want to try to diagnose endometriosis. The clinical diagnosis, as some of the newer studies and have been trying to look at, is important because we don't necessarily want to have to put patients through surgery just for the diagnosis. But again, to be able to diagnose endometriosis doesn't necessarily mean you can't treat the symptoms associated with endometriosis. So New ideas coming along the pathway of trying to not have to do surgical intervention include things like endometrial biopsies, looking at different nerve fibers, the C fibers, the unmyelinated sensory C fibers potentially can be looked at. There are other serum markers, although they're not very good. We're looking at potential combinations specifically to the microRNA and interleukins, because we know that endometriosis is an inflammatory disease as well. We'll get to that a little bit later. You're in collagen alpha-1 chain precursors and also circulating endometrial cells, looking at that in a woman's circulation to try to help diagnose endometriosis without having to do a invasive surgery. Some of the things that people look at when they look at for endometriosis are these typical type lesions. And when you see this, again, you have like a powder burn type lesion. You can have like reddish lesions, whitish lesions. This reddish lesion by the appendix. This is an endometrioma, which is kind of, we call it a chocolate cyst, where that is endometriosis. And then as you can kind of see in the lower slide, that's deep infiltrating endometriosis and the cul-de-sac is obliterated. So those are very difficult surgeries. And individuals that have significant endometriosis like this are very hard to deal with in terms of surgical interventions and potentially treatment options with fertility and sometimes pain. When we deal with endometriosis, so you can have some atypical presentations like endometriosis in scar tissue, endometriosis in the lung, and in fact, that's Dr. Kandalavala. I'm just trying to, give him a little poke there. Male endometriosis, and one of our own, Dr. Filoni, did a review of the literature for endometriosis in the male, and it is linked to the prostatic utricle potentially. So this is kind of a staging category that the American Fertility Society has put out, where you can kind of see that you've got stages, just like with cancer, there can be stages, and anyone that's initially had their first laparoscopic surgery should be staged for how far along the endometriosis is, and you can add up these points. The thing that's interesting though with stages is that you do not have a correlation between pain and the stage. So someone can have a stage 1 and significant pain, and they can have a stage 4 and minimal pain. So it doesn't mean just because there's more pain that they're a further along stage. When we deal with the treatment for endometriosis, which is primarily what we're dealing with our mouse model, is you're going to be dealing with the standard flare. So we're going to be doing non-steroidal medications. We're going to be doing combination oral contraceptive pills for control of the hormones. We're going to be dealing with surgery. So these are kind of the pathways that we go through. But in general, you're going to also have a lot of different options that are around. Now, when you deal with those different options, this is kind of a culmination of these societies that have put out recommendations about how you can go about actually with evidence-based medicine treating pain with endometriosis. And so ultimately, everyone's going to talk about non-steroidals and combined oral contraceptive pills, but there's other evil medicines like danazol. There's other medicines like medroxyprogesterone acetate. There's other medicines like the GnRH agonists, and then the GnRH antagonists. There's selective progesterone receptor modulators, and there's alternative medicines that people have tried to use to try to help with pain. And then there's also the surgical interventions. But if someone's 25, you don't necessarily want to do a hysterectomy on them to try to help their pain unless it's your last resort. When we deal with newer options, the exciting things that are out there, again, the selective progesterone receptor modulators come to mind, aromatase inhibitors, the types of medicines we use with breast cancer like the letrozole have been used with endometriosis, especially postmenopausal endometriosis. But you can see the gamut here of all of these areas that we can potentially be looking at to see if they actually can help with endometriosis pain in women. In general, though, the thing that I think that's important and points out to the fact that this is an inflammatory disease, it's an immune disease, is that these are the comorbidities that are associated with endometriosis. And this is where a lot of collaboration can come in. Celiac disease, SLE, your thyroid disease, inflammatory bowel disease, rheumatoid arthritis, multiple sclerosis, skin cancer, Dr. Hansen. Think about the kinds of things that we have. Ovarian cancer is definitely on that list. And when you look at cancers, you can see that endometriosis, when you compare the absolute risk of developing cancer in a woman over a lifetime compared to those that have endometriosis, that this is where it becomes a big issue when you're connecting the dots, right? That ovarian cancer, breast cancer, thyroid cancer, these are immune issues that we're dealing with. And that's what we're trying to help when we're dealing with our endometriosis patients. Now, how did this begin? Real quickly, it was kind of me dealing with some of the industry-sponsored studies. And so industry is not evil all the time, but we got a chance here at Creighton to help with the creation of two GnRH antagonist molecules that are on the market right now. So we were clinical trial sites for these two studies, or these two big studies that helped get these drugs approved. One is elagolix and one is relagolix and E2-neta, or the estradiol and norethindrone acetate. So ultimately, these molecules did show benefit in women that had endometriosis. And I think some of the important things that we have seen with these trials is that it's not just helping with pain, but decreasing or not increasing narcotic use. So that with the opioid crisis, again, this is very important. So I think we have some things to put our hat on that at Creighton, you know, we were part of the trials that were published in the New England Journal of Medicine and in the Lancet recently, to where it's like, this is something that our patients were helped to get these drugs approved, and we've looked at it on a clinical basis. And so that kind of brought me to Dr. Gelineau Van Waes, and she will kind of continue with our mouse model, so you guys can kind of see what we're doing, exciting things with our mice. And Khaleesi, I put it over to you.
Okay, hopefully you can see my screen now. So my chairman, Dr. Peter Abel, brought John and I together pre-COVID to talk about endometriosis and possible collaborations. And I was fortunate enough actually to be able to go out to Lakeside and observe John doing robotic surgery to remove lesions and do an ovariohysterectomy. So we started talking about what we could do in the lab in terms of maybe looking at novel therapeutic targets and figuring out how to treat pain and endometriosis and come up with something that wouldn't further compromise fertility, and started looking into what animal models were available. And there are a lot of challenges with animal models. Baboons and rhesus macaques develop spontaneous disease, but obviously it takes years, and maintaining a colony of primates for years would be incredibly expensive. There are not very many species that menstruate like people do. So in addition to the higher primates, there are some bats, the elephant shrew, and the spiny mouse, but those are the only species that menstruate. We did talk about or think about the spiny mouse at one point, but it's a unique little mouse that is native to the deserts in Africa. It has a much longer estrus cycle, a longer gestational cycle, only has 2 to 3 pups per litter, and they're born with their eyes open. But anyway, it's more, there's a colony in Australia and a colony in the US. That's it. They're not commercially available. And they're more studied for tissue regeneration, because when predators grab them, their skin peels off and then regenerates. So looking at what other models would be available, rodent models, There are various rodent models, rat and mouse, that have been published, but in looking through the literature, there's really a lack of a standardized model available. And all of them, have their merits, but there's variable degrees of fidelity in all of these models in terms of recapitulating the pathophysiology of human disease. So there are diverse methods of transplanting endometrial tissue into the abdominal cavity. Some people chop up the uterus and inject it in a slurry into the peritoneal cavity. Some people do an invasive laparotomy and actually suture pieces of the uterus to the abdominal wall. There's variability in terms of the type of tissue that's transplanted. So some of the injection models, it's just endometrium. With the suture models, it also includes the myometrium, which is not characteristic of human lesions, but I don't think you'd be able to suture the tissue to the abdominal wall if you were using only the endometrium, because it would fall apart. The cycle phase of the donor and recipient at the time of transplant were often completely disregarded. The immune status of the donor and particularly the recipient is important. A lot of the models use immunocompromised recipients so that they can transplant human tissue. But we know that the immune system plays an important role in endometriosis, so you're kind of bypassing that aspect. The ovarian status of donor and recipient, a lot of the models, they had ovariectomized them, either the donor and or the recipient, and then replaced them with exogenous estrogen to try and get increased growth of lesions. And then the focus really in terms of endpoints was on number, size, and weight of the lesions. And clearly you need to have the lesions present, but as I'll show you when I show you pictures of our lesions, they're really variable in terms of the size and the shape. So when people report diameter or length or volume or even weight, some are wet weight, some are dry weight. I think they're very tiny lesions. It would be very difficult to discreetly dissect only the lesion and not have any of the surrounding tissue. So I'm not really sure how reliable weight is as a measure. And we know that the number, size, and weight of the lesions don't necessarily correlate with the clinical symptoms. So, we started thinking about translational relevance of all of these different models and how we could further optimize the model we wanted to use. So we wanted to use the mouse. Some of the limitations, obviously, they don't menstruate. And unlike humans, where the fallopian tubes are open to the peritoneal cavity, mice have a complete ovarian bursa. So retrograde flushing of endometrial tissue out the end of the fallopian tubes was not an option. Clearly, benefits of using mice, you can have genetic variants that you can look at, and they have a normal estrus cyclicity, normally 4 to 5 days for an estrus cycle. So we started actually our model long before this paper came out we started pre-COVID. This paper came out in January 2022, talking about actually exactly what we were concerned about, that there really wasn't a best fit model out there. And they kind of laid out the parameters for what they thought would be a best fit. We have accomplished 4 of these: spontaneous endometrial attachment and growth of lesions. We don't suture them. We have menstrual phase endometrium at the time of implantation. Our mice are immunocompetent and have intact ovaries, so normal hormonal milieu. We attempted to do a longitudinal assessment of endometriotic lesions by IVUS imaging, and I'll kind of touch on that and some of the problems with that. And then iterative endometrial transplantation. So, as the tissue would presumably have retrograde menstruation every month in a woman, that you would have this happening multiple times. And In an animal model, it would be really hard to justify doing multiple survival surgeries when with a single surgery, we were able to induce lesions that were still present 90 days out. So just in terms of our ideal model, they're immunocompetent, have intact ovaries. We don't do any exogenous hormone replacement. We use menstrual endometrium, donor endometrium, to implant into the peritoneal cavity. Both our donor and our recipient are menstruating at the time of implant. So we have them matched in terms of timing of the cycle. And this is something that nobody has yet published. We use a minimally invasive laparoscopic surgical technique. The lesions spontaneously attach and grow, and our animals return to normal estrocyclicity after post-op, about 7 to 10 days post-op. And we haven't tested fertility yet, but we're assuming that they're fertile since they're cycling normally. So this way we have a model where we can evaluate potential therapeutic targets for managing the clinical symptoms without impacting fertility. So we initially started with our donor mice being an albino B6. They have a mutation in the tyrosinase gene, and they express mCherry, so a red fluorescent protein, because we wanted to be able to image donor tissue in our recipient. So our recipient is just the B6 with the tyrosinase mutation. To control or minimize exposure to xenoestrogens, they're housed on paper bedding rather than corncob bedding, because corncob bedding can contain mycotoxins that have estrogenic properties. We also feed them a soy protein-free diet to minimize exposure to phytoestrogens. So this is our experimental design. We have the mCherry donor and the B6 recipient are mated with a vasectomized male to induce pseudo-pregnancy. On the morning of the vaginal plug that would indicate copulation, we call that day 0.5. And then on day 4.5, which would normally be the time of implantation for the mouse, we decidualize the uterus by injecting with a blunt needle sesame oil through the cervix and into each uterine horn, followed by mechanical stimulation. The pregnancy continues then until the time when a placenta would be forming. Since they're only pseudo-pregnant and the placenta doesn't form, they actually start to bleed or menstruate. And so at this point in time, we sacrifice the donor, harvest the menstrual endometrium, implant it laparoscopically into the recipient, and then follow them out to 30, 60, or 90 days post-op before we harvest lesions. And we always sacrifice them on the first proestrus after 30, 60, or 90 days. So to generate the menstrual endometrium, we modified the Rudolph protocol. They actually overectomized the donor and recipient and implanted them with exogenous estrogen and progesterone. And then when they remove the progesterone, the mice start to menstruate. So we modified this, and as I just described, we do the pseudo-pregnancy and the decidualization at day 4.5, and then do vaginal cytology to confirm bleeding. So here we have our menstruating mouse on day 9.5, confirmed by the presence of red blood cells in vaginal cytology. And this is what the decidualized uterus looks like on day 9.5 when we harvest it for tissue. So just for comparison, this is what the uterine horn looks like in a control that's not artificially decidualized compared to the one where we're going to remove the tissue. So we harvest, we remove the myometrium, and we have only the endometrium, and then we take discrete tissue plugs from that, which we then implant laparoscopically into the abdomen of the recipient mouse. So the mice are anesthetized, intubated, placed on a ventilator and a heating pad with a rectal probe. We place the endoscope. It has a light source and CO2 insufflation, and we can visualize then on the monitor the tissue plugs that are being implanted. So here's John, and here's Dr. Christy Howe, our attending veterinarian. And then after we've placed the 10 plugs, remove the endoscope, suture them up, and recover the animals. And Dr. Christy Howe has been just completely instrumental in tweaking this to get it to work so that it's really smooth right now. We had a lot of bugs to work out in the beginning, and we kind of found that the intermittent insufflation, the mice recovered better than if we had them constantly insufflated. So here are some of the lesions then that we've harvested. If we implant 10 lesions or 10 plugs of mouse, our average take rate is 2.6 when we harvest them. All of our mice have some lesions, anywhere from 1 to 5. I think 5 is the highest we found. So about 100% of the mice have endometriosis. And then they return to normal estrus cyclicity. But I think you can see what I was talking about, that they're very different shapes, and they're very tiny, only about a millimeter and a half. So we formalin fix, paraffin embed the section or the tissue, and then they're H&E stained, and this is done in the histology core. And then we gave the slides to Dr. Catherine Stuess to do the histopathology. So we found lesions in inguinal fat pads attached to the abdominal wall, to the bladder, as well as various other sites. So attached to the uterus, the ovary, in the mesentery, attached to the pancreas, cecum, and jejunum. And we sometimes have found adhesions as well. This is just kind of showing you, we did try to do some IVUS imaging of the lesions, and we didn't really feel like it had great resolution, but before we were able to further tweak it, the machine went down, and it's still not working. So we haven't followed up with the IVUS imaging of following these lesions longitudinally. We've done some immunohistochemistry. We have new vessel formation or angiogenesis in the lesions, as well as foci of proliferation. So all in all, we think that our model recapitulates what is seen in the human condition, and we can use it then to determine mechanisms of pathogenesis, perhaps identify biomarkers that could be used diagnostically, evaluate the contribution of genetic variants and the impact of xenoestrogens. But for now, our focus has been really to look at potential novel therapeutic targets for treating pain that wouldn't further compromise fertility. So our focus really has been on the role of the G protein coupled estrogen receptor. Most of the literature focuses on ER alpha and ER beta. Not much work has been done on GPER. However, GPER is overexpressed in both the eutopic uterus and ectopic lesions of women who have endometriosis. So it's most highly expressed in the proliferative phase of the menstrual cycle, and dips mid-secretory phase when progesterone is high, and then increases again. So levels should be fairly high in the menstrual endometrium that we're harvesting, because it increases with stromal decidualization in the late secretory phase. So as I mentioned, GPER is overexpressed and actually in all phases of the menstrual cycle, and eutopic uterus and ectopic lesions in women with endometriosis. And we know that the G1 or GPER agonist can stimulate proliferation of uterine epithelia in mice. We looked at expression immunohistochemically of GPER in our endometriotic lesions from our mouse model. We started out with DAB, which is a little hard to differentiate from the background hemosiderin staining. So we used Discovery Purple as a chromogen, and you can see that GPER is highly expressed in our endometriotic lesions. GPER not only can be activated by normal endogenous estrogens, but is also sensitive to activation by phytoestrogens. So the soy-based diets, as well as xenoestrogens or endocrine disruptors, including bisphenol A and phthalates. We have some agonists, selective agonists, as well as antagonists that can be used for preclinical research, and we've obtained those. And just to follow up on something that John mentioned, not only is endometriosis associated with various cancers, but GPER, which is upregulated in endometriosis, plays a role in the development and immune response in several different female reproductive cancers, so breast, cervical, endometrial, and ovarian cancer. So to look more closely at GPER in our endometriosis model, we have obtained some genetic tools as well as pharmacological tools. We cryo-recovered a GPER knockout colony, established a breeding colony, and are currently looking at the role of GPER in the donor menstrual endometrium versus recipient ectopic lesions. So the environment in the recipient versus the donor. So we're doing the donor and recipient different combinations of wild type versus knockout. So far, we've only opened one mouse that was knockout donor to knockout recipient, and the lesions are present, but they are more fleshy colored. So we'll have to see how that holds out. And then we have plans to evaluate the role of GPER in oocyte maturation and female fertility. We have pharmacological tools. So we have a G1 agonist, as well as the antagonists. We have G1 in 90-day slow release pellets for sub-Q implantation. We're currently performing pharmacokinetic analysis, and we are implanting these pellets subcutaneously at the time of surgery so that we can evaluate our different endpoints and expression of GPER in lesions that are harvested from mice that are exposed to chronic G1 agonism. And we're also working with some other people in our department, Drs. Jadov and Pant, to develop novel GPER antagonists and design cell type specific drug delivery systems. We think that GPER expression in mast cells may play a role in endometriosis associated pain. In a rat model of irritable bowel syndrome, activation of GPER triggered mast cell degranulation, release of histamine, and caused abdominal sensitivity and pain. And we do see quite a few mast cells, these dark purple, in our endometriotic lesions. So that's something that we want to look at, the role of GPER and mast cell degranulation in endometriosis-associated pain. We also see quite a lot of macrophages that are associated with our lesions. Lesions tend to have macrophages that have the M2 polarization or anti-inflammatory, sort of pro-survival phenotype. And a marker of M2 macrophages is CD163. So this is, I only have this one picture because this was the optimization slide for the antibody. But we do have positive staining for CD163 positive macrophages in our endometriotic lesions. And then some very recent papers, so in the last 2 years, have shown that GPER heterodimerizes with the follicle stimulating hormone receptor and may play a role in oocyte maturation. So there might be a role for increased levels of GPER in endometriosis associated infertility as well. So once we finish the characterization of what G1 agonism does and look in our knockout versus wild type mice, we want to look at whether or not GPER antagonists will be effective in treating a number of different things. So preventing mast cell degranulation, preventing M2 polarization of macrophages, preventing the perhaps infertility that's associated with endometriosis. So trying to wrap up here, acknowledge John, who was instrumental in getting this all rolling and helping us get some donated equipment from the hospital to get started. Dr. Howe, who's been just a critical piece of this whole project. Dr. Catherine Stuess, who did our histopathology, Jody Hallgren, technician, and Marley Bredehoft, who's a graduate student. We have had a number of medical students participate in this project. And we have now, since Dr. Stuess has left, 2 pathology residents who have graciously agreed to do our histopath. Of course, Dr. Peter Abel, my chairman, and Dr. Robin Farias-Eisner, even though he's left, were both incredibly supportive from the beginning of this project. The Creighton Animal Resource Facility for taking good care of our animals, Tony Howard in the Histology Core Facility for doing our tissue processing and sectioning and H&E, and Melissa at UNMC, who's been incredibly helpful with the immunohistochemistry. And then as far as funding, we've just had some startup funding. We had Haddock's grant, and now currently have an HSSI grant that's gotten us up and rolling. So hopefully we can, well, we have 1 DoD grant pending, and hopefully can start applying for some federal funding. That's it for me.
Thank you. Really interesting stuff. It is open for questions or comments, suggestions. Maybe while people, which you can either put in the chat or you can unmute and ask. I'm going to ask one while we wait for people to get themselves organized and put it in the chat, etc., or whatever. So in your DoD grant or in your future plans, it looks like a really powerful model, and you know, this focus on G per, you know, a molecular target, I guess, or influence. I wonder is also a really nice feature of what you've done. I wondered what the hypothesis or the focus of your DoD proposal are. You know, it is your hypothesis and, you know, the aims in brief on that grant.
Yeah, there's 2 aims, and one of them is to look at deeper activation of mast cells and visceral hypersensitivity, so pain, and we would need to purchase some equipment to do that, to measure vaginal. It's a model where they use electro EMGs and electrodes and latex balloons that are inserted into either the vagina or the colon and expanded, and then look at visceral hypersensitivity and endometriosis versus a model that doesn't have endometriosis. And then the second aim is to look at macrophage polarization, role of GPER in macrophage polarization to the M2 phenotype, and we wanted to do some single cell RNA-seq as well as flow cytometry to really drill down on the subpopulations of macrophages that are associated with the lesions.
So the hypothesis is that GPER leads to these mast cell and macrophage activation that contributes to the pain with endometriosis rather than necessarily like progression or making or
well the anti-inflammatory M2 macrophages would contribute to survival of the lesions rather than them being cleared and phagocytized. So survival and proliferation of the lesions, and then the mast cells would be involved with the pain piece of it.
So you're implanting endometrial tissue into GPER knockout or wild type mice, so you'll
Yes.
know specifically the effect of that gene, and then would you want to look at like targeting mast cells or macrophages specifically in a knockout system to confirm that in like later proposals? Or
yeah, that's where we were working with Dr. Jadov to design some cell type specific delivery systems. So if we could specifically target a G-per antagonist, say to macrophages or to mast cells.
Really interesting. Any other comments? I have a lot of questions and curiosity about it, but are there other comments from our audience? Go ahead.
Hi. I just have a comment. I don't have a question. I just wanted to say I am really enthusiastic about this whole line of research and really considering COVID, really impressed at how much preliminary data and how much you guys have been able to do over the past couple of years to get this model up and going. And I'm really, really excited about this project. I think it's fantastic. That's all. And thank you very much for presenting today. It's just really exciting.
Hey, Janine, it sounds like you are really now focused on the inflammation, macrophage and the from M1, M2 the type change. Do you have any like immunologist or someone like have a more experience in that field as the co-investigator of your grant?
I don't. I would love to have collaborate with somebody who has more experience in immunology. Also, anyone who is expert on, ovaries and follicle maturation and fertility piece of it.
Yeah,
that we'd like to get into.
I mean, from future grant submission, and it sounds like, I mean, right now you two, very good team for that model, and also the those adding additional collaborator as the team members. I think that's very important because it sounds like you particularly M2 is a lot of like inflammation, immunology. This is might have to have someone. Oh
my.
Yeah. Okay. So I guess that's part of might be very important, Also, this is your.
I agree. The DoD grant was sort of similar to an R20. No, it was even less. 300,000 for 2 years. So the budget is not huge. So we were really, and we have to purchase some equipment. We'd have to purchase some equipment with those funds. So we kept it small, but hopefully we'll get some pain data and some more.
Yeah. So I guess this is, I don't know whether you should consider submit as R21, but maybe this 2M is a fit with R21, but I don't know whether the institution you're go for that is still supported R21 mechanism. And the second,
well, so the only reason that we haven't submitted the R21 yet is we thought it would be stronger when we get our paper of the model published.
I agree.
And I mean, that's currently Christy's working on that. She's going to be the lead author on that.
Okay.
So as soon as we get that out, I think it'll because right now this whole field of endometriosis, I'm new to endometriosis. I've never published in this area, so I think that has to happen next. We need to get our name out. We did present our poster at the Society for Reproductive Investigation meeting in Denver last spring, and we had a lot of we were in the late breaking abstract session, and we had a lot of people stop by and even take pictures of our poster. So it seems like it was well received. Our model was well received.
Yeah, I think that NIH, I don't know DoD, but I'm sure that for an NIH application, they're going to love the team of the two of you, clinician and basic scientist, but then, yeah, for sure, especially if you're heading in the direction of inflammation, having the right collaborator is going to be key.
Mhm. I
Maybe
agree.
otherwise, it's easy for the member to toss your proposal out. Yeah, it's a.
Yeah.
I think we have a great need for more individuals doing inflammation work related to inflammation, anti-inflammatory drugs, etc. Here at Creighton in general, the
Mhm.
basic as well as the clinical sciences.
Yeah.
I think we need to think about hiring people in that area.
Even
Well-
I'm self also looking for collaborator in the
Right. Dr. Jadhav as well.
Yeah.
Hmm. I wonder if, as MedMicro have some hires,
Plan.
coming up in the next years, I don't know. I think Dr. Bartz is out of town, but I don't know if there are other MedMicro folks here, but I agree. I mean, it's so key for all kinds of diseases, cancer for sure.
Right. And I don't know if we're hiring clinicians who have expertise in immunology as well. That could also strengthen what we're trying to do.
That's a good question. I have conversations with people at CHI regularly, and I'll bring that up. I did notice also we have a number of people, clinicians from Phoenix on the call. I don't know if Dr. Curtis, if you're there, if you know of anybody on the Phoenix side who might be interested in collaborating, or others on the Zoom. Let's see who else is here.
Hi, it's Dr. Rubenstein from Phoenix. How you doing?
Hi.
Academic chair. So the ask is obviously any collaboration that we can help with for this with our resources that we have would be, I think a wonderful joint opportunity and patient populations.
What chair or what department are you chair of?
OBGYN, Dignity Health
Okay.
Medical Group,
Okay,
Vice Chair of Creighton University School of Medicine, OBGYN Department with Dean Coonrod as the chair.
okay. Awesome. That sounds like a great offer.
One thing that I've been trying to do too is with Dr. Conrad and talking with Dr. Stessman, Holly, is trying to, with their biobanking, look at trying to biobank potentially or get in some of our endometriosis patients. And I think it would be great to see if we could get some kind of collaboration with our partners on the Phoenix campus. And that would be a huge benefit in terms of diversity piece to this, not just with the cancer piece, but with potentially endometriosis. And like I said, I mean, that's it. There is that link with the cancer piece. So I think that trying to get some funding through that particular avenue would I think help as well. But Dr. Rubenstein's been awesome. I've been talking to him recently, and they're really proactive about trying to collaborate. And I think we just need to get people out there that want to work together and that are talking to each other. So, I appreciate everything that everyone's been doing to kind of extend that forward.
We do have a large endometriosis practice, A, within the medical group here, and B, in the fellowship that we have, advanced gynecology consultant, in the Scottsdale area does a large amount of endometriosis, and another provider who's also part of the fellowship as a community provider does have a large in the East Valley, a large practice. So similar. So I don't think that we would have problems with the numbers. I think it's just now, how do you operationalize? How do you coordinate? How do we have the IRB protocol set up that we can perform this? And as Dr. Cote says, is really the biobanking component of also.
Mhm.
Do we have two separate biobanks? Do you have now Creighton, Nebraska? Do you have then Phoenix? And then how do you, material transfer agreements? How do we transfer that to the respective biobank? Where do we want to put that? We
Is
also-
Holly on? I don't know if Holly's on. Is she on now? Probably not.
And
Uh,
I was just going to add, with us here, we also have an affiliation with Arizona State University. So there's opportunities for us to utilize some of their labs. I know they're very much interested in further collaboration. I think this is a very easy ask. Just the task of moving it forward is the harder part of it.
Yeah. I mean, Arizona State is so huge. I can't believe that they don't have immunologists there. If they're interested in this work and this project, which I know generally they're really excited about collaborating in more clinical directions because they don't have a medical school
exactly.
there.
Yeah, the maternal
Um,
child health translational research team I sit on, which is about 160 multidisciplinary team members. So we're able to really to pull from that and utilize their task force and their committee members to then continue to evolve as the projects require as need.
yeah. Do your fellows have significant time for research?
We have one fellow now, and I think that was been one of our program deficiencies is that lack of time for research. So I think something similar to this would be only additive to that. So definitely they have the bandwidth to do it. I don't think they have the time necessarily to do it. We have more of the infrastructure now than we had in the past. This just adds that next layer of infrastructure.
Mhm. I think, I mean, there are some groups here. I see Dr. Conrad, part of those groups is on this Zoom. I mean, there are a number of people here in Omaha also, working on uterine cancer and endometriosis, etc. And I wonder if it wouldn't be really useful for all of you to get together for a few really focused meetings to talk about these issues of, coordinating across campuses and what kind of infrastructure you need. And my office for sure is there to help things move forward and, facilitate whatever we can with setting up those conversations or, providing support however we can. I don't know, would that be, are we at that stage? It seems like a pretty good sized group of folks that are interested, or if you also have, residents or fellows who are interested in contributing to this, I think sometimes they can provide, hands-on time to help move things forward too.
Yeah, I think, from a benchtop research point of view, I think we have some limitations. Though I think with the expansion to ASU, one of our faculty is Dr. Carl Wiener is an MFM who's looking to do a little bit more of that benchtop opportunities. He's got 2 RO1s going in and an RO3 going in at the end of this month, October, I'm sorry. And with our residency, for OBGYN, we're definitely looking for ongoing QI and obviously research-based projects, especially as they are required for their residency. But that's, we have 8 to 10 residents per year. So we have a 38 resident program. So definitely an opportunity. If we add this and broaden this to our pediatric and adolescent gynecology fellows and team that's at Phoenix Children's Hospital, I think, again, another additive benefit of some of the work that we're doing in Phoenix. Our Reliance Master Agreement with Phoenix Children's Hospital didn't exist until just a few months ago. So I'm happy that can help and be additive in many ways. And the Cancer Institute here with Dr. John Farley is our GYN oncologist within the medical group. Though I don't think our numbers, I can pull that from our team for uterine cancer component of it, if you were looking at that, is that large. There's a very diluted GYN oncology groups out here. There's a large number of providers scattered throughout the valley.
Okay, and the person you said was putting it in the R01s and R21s is Arizona State, or that's?
No, that's separate. Is one of my faculty is Dr. Carl Wiener, who's a maternal fetal medicine specialist.
Uh-huh. Well, I think it would be wonderful if we could get him to present to this group, because I'm unaware of his work, but and also, you know.
So his is right now is based on RNA and preterm birth.
Okay.
So I can definitely reach out Dr. Hanson
yeah.
to Carl and connect you guys for one of his presentations.
Yeah, and we also have a mock study section, which I don't want to take up our time, but we have a mock study section to provide pre-review of NIH applications before they go in, which has been really effective at helping people put in more successful applications. We did get, I think, from Brittany Taylor, a message that she's a third-year med student, would love to be involved in
Great.
your discussions.
Just so you know,
yeah.
women with endometriosis have an increased risk for preterm labor, Dr. Rubenstein, just so you can tell your staff that.
Yep.
All right, well, we've reached 2 o'clock. Seems like a lot of energy and enthusiasm and people involved. Maybe we will try and reach out and facilitate some further conversations of the group. Or, you know, if you guys need help or, you know, want some help getting in touch with people and putting that together, we can do that. That'll probably be Brianna Conyers, who's our Director of Research Programs, will be facilitating that. So that's really exciting. Thank you all for being here. I think
Okay.
this was very interesting meeting. So we will look forward to seeing you all on October 28th for our next research brainstorming.
Okay.
Have a good
Bye-bye.
weekend.